Good evening, everyone. This is a new paper which is recently published, September issue. It's published in IOSR, Journal of Dental and Medical Science, September issue. So the title goes like an extensive evaluation and meta-analysis of transcranial magnetic stimulation effectiveness as a treatment for Alzheimer diseases. So quickly moving to abstract, the background goes like for the treatment of Alzheimer disease, repetitive transcranial magnetic stimulation or RTMS is frequently employed. So the impact of RTMS is still debatable, but still though the current study objective is to assess RTMS impact on Alzheimer disease patients' cognitive function. So the method is like before April 20th, 2022, I conducted a thorough search of pertinent literature in 4 main databases. Those are PubMed, Embase, Web of Science, and Cochrane Central Register of Controlled Trials. And so there were both cross-section studies and randomized controlled trials that compared the aiding power of RTMS with no stimulation or SAM stimulation. So the results were a total of 14 studies involving 513 Alzheimer's disease patients. Those were finally included for meta-analysis. It was found that RTMS significantly improved global cognitive function. So later we'll talk about in results. And but in patients with Alzheimer's disease, but it did show target with language, memory, executive ability, and mood. In further analysis, RTMS at 10 Hz on a single target with 20 sessions of treatment was shown to produce a positive effect. So in addition, improvement in cognitive function lasted for at least 6 weeks. So the conclusion is RTMS can help Alzheimer's disease patients with their everyday functioning and general cognition. Additionally, RTMS safety in patients with seizure needs to be taken into consideration. So the results should not be taken too seriously due to limited sample size. Let's quickly move to introduction. One of the main causes of reliance disability and death. Dementia is an acquired gradual cognitive impairment that interferes with daily tasks. So there are currently over 44 million dementia patients worldwide. And as an aging population grows, it is predicted that number will be triple by 2050. So AD, which affects 50 to 75% of dementia that suffer, is the most common cause of dementia. After the age of 65, it is prevalence substantially doubles every 5 years. So it primarily shows itself as cognitive impairment, aberrant psychomotor activities, and social disengagement, all of which considerably raise the risk of emotional discomfort and detrimental effects on both physical and mental health. So there are now 5 drugs that are approved by FDA to treat Alzheimer's disease, including glutamate, receptor antagonist, mematine, and acetylcholinesterase inhibitors. So clinicians and researchers are searching for a solution in area of non-pharmacological intervention due to limited effectiveness of current pharmacological therapies for recovering brain functions. So this research is based on RTMS, that is a transcranial magnetic stimulation, that is a non-invasive treatment. So that may enhance cognitive ability and neuroplasticity. So it is being given more thought as a possible therapeutic approach to treat Alzheimer's disease. So a non-invasive neuromodulation approach is TMS. Its magnetic pulses passes through the layer that is separating the skin surface from the brain surface. Variations in the magnetic field strength produce electric field that can stimulate particular parts of the brain. According to researcher Gang Tiano et al., it has power to control not only the excitability of nerves and the operation of cortices, but also the activity of specific neurons. So in order to treat depression, pain, fibromyalgia, post-traumatic stress disorder, non-fluent aphasia following stroke, and cognitive impairment, it is frequently employed through. So although numerous clinical trials and meta-analysis that have examined the effectiveness and safety of repetitive TMS or RTMS for patients with Alzheimer's disease, as no consensus has been reached. So the effect of single point stimulation, multi-point stimulation, and the number of treatment sessions, and the combination of treatment with cognitive training on Alzheimer's disease were not reported in a recent meta-analysis that summarized the findings from randomized control trials that were published in PubMed and Web Science. So in order to get a clear conclusion regarding the effectiveness of RTMS in managing AD from many angles. So I therefore conducted this systematic review and meta-analysis on all RCT and cross-section studies that is published by April 28, 2022. Analysis was also done on how RTMS affected several cognitive domains as well as general cognitive functioning. So the material and method goes by presenting a conducted study by complying with the PRISM PRISMA guideline for systematic evaluation and meta-analysis. So this study was registered at Prosperol. So search approach for literature using the following keywords: Alzheimer disease or dementia of Alzheimer type, or AD and transcranial magnetic stimulation, or repetitive transcranial magnetic stimulation, or RTMS or TMS, and randomized controlled trial or controlled clinical trial, or cross-section, or randomized or placebo. Or researcher independently searched literatures in PubMed and Best Web of Science and chosen from among these articles. It is referred to those. So a senior investigator, Dr. Aditya, was invited to review the paper against the inclusion and exclusion criteria. So the eligibility criteria was according to NIA, National Institute of Neurological and Communicative Disorders and Stroke, the Alzheimer Disease and Related Disorder Association, all full text randomized controlled studies and cross-section studies published in English, the Diagnostic and Statistical Manual of Mental Disorders, DSM-4 and DSM-5. Our RTMS was administered to an age and sex-neutral population with an AD diagnosis were eligible. So RTMS was the only different intervention for particular cortical regions, and SAM RTMS in the same cortical regions were designated as the control conditions. So cognitive related neurobehavioral outcomes include changes in cognitive domain between pre and post intervention. Cognitive measures, so when database and the other records were recorded, the greatest number of patients or the most comprehensive information was used. So data extraction. In this research type, population characteristics such as age, sex ratio, years of education, and the course of disease, diagnosis criteria, type and characteristics of stimuli, including intensity, frequencies, sites, and session of treatment. Neurobehavioral outcomes, that is mean and standard deviation, SD and AD. So were independently extracted by researcher from each included study. So studies were mined for quality evaluation of the listed studies. So we extracted changes in outcome before and after treatment in a single group for cross-designed clinical research. So results from clinical studies with several treatment groups were combined and analyzed. The respective authors were contacted to request the mean and SD when they were provided in the text. So by doing quality evaluation, creation of random sequences, counseling the allocation, implementers and participants are rendered blind, blinding the evaluation of the results, reliability of the outcomes, strict reporting, and additional biases. So analysis of data. The Costren REBMAN 5.4 software was used for statistical analysis of the data, calculating and reporting the standardized mean difference. That was 95% confidence interval for each major outcome, which describes an intervention affects outcome and an effect of considered significant with potentially clinical relevant. So reports on global cognitive functions, MMSE, MOCA, ADAS, COG, and AS3. So the language, sentence comprehension, test memory, the ability to execute, TMTA, daily life ability, IADL, and emotion, GDS, were included in meta-analysis. So was used to evaluate the heterogeneity of the included studies. So when 50%, it was considered to have low heterogeneity, and the fixed effect model was used. So when 12 value, that is minus positive, goes to 50%, so it was considered to have high heterogeneity, and the random effects model was used to summarize the effect size. So this is the main formula which was used by mean change, mean final, and mean baseline. In all analysis, P is smaller than 0.05 was considered statistically significant. So we again move to the results. A total of 1059 articles were found in 4 major databases. So total of 263 publications were excluded due to duplicate and incomplete basic information. So when the full text was inspected, 2 were excluded because of single arm nature, 5 because of inconsistent control measures were taken. So the meeting summaries and reviews. This is the figure 1. Goes by records identified through database searching. You can see in the figure. Addition records, that was the publication excluded, title and abstract, and all those things. So the information of included studies, a total of 513 patients with varying degrees of severity were included in this meta-analysis. Their age was from 60 to 80 years and 53.5% of them were female. Demographic information of participants was summarized in table 1, types and characteristics of stimuli in table 2. Basically, SAM RTMS was similar to the real RTMS in sound and feeling, often contacting with the head, but did not produce actual therapeutic effects. So generally, the coil was tilted away from the head to achieve the purpose of false stimulation. For example, in the study of the Gia et al., the same coil was tilted 45 degrees from the scalp so that one side of the coil was in contact with the scalp and the distance between the center of the coil and target site is greater than 5 centimeters. So patient would also feel the noise sensation caused by same stimulation. So the coil was perpendicular and flipped 180 degree, and the scalp in the study of Chang et al. 2019. In other studies, special fake coil was used, or the coil was attached to the scalp, but no therapeutic stimuli were applied. So this is the table from every researcher which I found in the database. So the parallel, the most of them are all parallel in design. Participants, these are the sex, male and female age, mean age years, mean education, mean disease duration, and diagnostic criteria. So all of them were parallel, but the cross-section one is the different. It goes by RTMS, SAM14, 7x7, and diagnostic criteria was nil. So these were the demographic characteristics, including trials. So high frequency RTMS, HF-RTMS was dominantly used by included studies with 7 studies. That was adopted in high frequency up to 20 Hz. Basically, the stimulated Broca and posterior temporal T5, T6 regarding the type of coil used for stimulation. The H-type coil was used in study of Leochrine et al., whereas the rest of studies used the H-shaped coil. Among the 14 studies, the majority of them adopted 10 to 30 sessions with a maximum of 54 and a minimum of 5 sessions. So the studies reported cognitive performance at follow-up ranging from 1 to 10 months. So other studies were reported adverse reaction during the treatment. So quality of included studies. The quality of included studies were independently assessed using the Ray-Ban software by 2 researchers, and the cross-design and the test were randomized controlled trials. So these indicate that the overall quality of included study was good. So you can see the random sequence generation, allocation, binding of participants, binding of outcome assessment, incomplete outcome data, selective reporting, and other biases. It goes by the year 2012, 21, 21, 22, 19. So the general cognitive function and repeated transcranial magnetic stimulation, the main one. The 13 studies were assessed, but the impact of RTMS on global cognitive function, namely the mini mental state examination, MMSE, Montreal Cognitive Assessment, MOCA, Edinburgh Cognitive Examination, 3, ACE3, and the Alzheimer Disease Assessment. That is also measured by scale cognitive subscale. So among these studies, 3 used MMSE and ADAS-COG scale to assess patient global cognitive status. So 6 studies counted MMSE results, and the 4 studies counted ADAS-COG results. So the above findings showed that RTMS significantly improved global cognitive functions. That was also measured by MMSE or ADAS-COG in 80 patients. So when subgroup analysis was conducted to discuss MMSE and ADAS-COG respectively, so RTMS still had a significant effect on global cognitive functions of Alzheimer's disease patients. That was standard mean deviation 0.59 to 95% CL, 0.36 to 0.81. So it should be noted that MMSE score is a positive indicator, and the higher the score, the better the cognitive status of the patients. These are the calculations and the mean deviation, which was calculated in graph. So when ADAS-COG is a negative indicator, that is the lower the score. So better the cognitive status of patients,
In our map, the abscissa is defined according to MMSE score. So that is the left is the SAM stimulation group, and the right is RTMS treatment group. So however, for subgroup analysis of ADS EOG, we accurately calculated the results of each study. So the SMD values of subgroups that fell on left indicated that the RTMS treatment was effective. So in particularly, additionally used the MOCA scale to show that RTMS had a significant treatment effect. That was 2.3 positive negative 6.36, and mean SD is like 1.2 to 7.02. So in consistent existing RTMS intervention, still the parameters among the included studies, and we conducted subgroup analysis on stimulation frequency. So stimulation sites and the number of sessions of treatment as shown in figure 4 compared to the RTMS at 20 Hz, stimulation frequency at 10 Hz, and more significant effect is like SMD 0.29 to 95% CR. So when analyzing the influence of stimulating loci, it was found that single stimulation of L minus DL PFC SMD 0.84 to 95% CR. So in multi-point stimulation is more higher, 0.30 to 95% CL to 0.00 to 0.61. So in addition, the therapeutic effect was most significant when the number of treatment sessions was 20. So it goes by SMD 0.61, 95% CL, 0.28 to 0.95, and followed by treatment sessions over 20. So no statistical difference was observed when the number of treatment sessions was less than 20. So some of the studies in meta-analysis also provided participants with supplemental cognitive training when assessing the impact of RTMS on global cognition, but the content of cognitive training varied between studies. This is the figure 4. You can see the impact of repetitive transcranial magnetic stimulation and the frequency in global cognitive functions. This is the deviation which is increasing. Here it is decreasing. As same goes here because it's repetitive. On RTMS stimulation site, it is repeating. This one is like influence of sessions of repetitive transcranial magnetic stimulation. That is treatment and basically globally cognitive function. This is for global cognitive function. According to standard mean deviation, here it is increasing, a little bit decrease, and here fully decrease. So the cognitive ability is increasing. So my results showed that RTMS combined with cognitive training had no statistically significant effect on global cognitive functions, SMD 0.48, 95%. But RTMS without combined cognitive training seemed to be superior to the former in improving global cognitive functions. So the statistical significance of result remained to be explored. Among the included studies, 6 reported post-treatment effects and had a better effect when follow-up time was 6 weeks. And more than 6 weeks is like SMD 0.53, 95% CL. The influence of repetitive transcranial magnetic stimulation on daily living. So among the studies, we included 3 studies that was analyzed daily, living using the IADL scale. The results showed that RTMS could significantly improve the daily living ability of 80 patients. SMD 0.64, 95% CL, 0.21 minus 1.08. That is final P 0.007. As you can see here, the forest plot showing the effect of repetitive transcranial magnetic stimulation. The patients with 95% CL. Directly, it's decreasing. The cognitive abilities has been increased and it is already decreased. So the impact of repetitive transcranial magnetic stimulation on language. So the sentence comprehension test was used to evaluate the listening comprehension of 80 patients, and the results showed that RTMS had a significant therapeutic effect on language. In contrast, the study of the language results of MMSE scale did not show significant improvement, but study by another researcher, Zhang et al. 2019, had although the therapeutic effect of RTMS on language that was observed by ACE3 scale. So that result was not statistically significant, P equals to 0.08. So in addition, other studies showed a significant improvement in speech function in patients treated with RTMS, and the results were statistically significant, P equals to 0.003. So, however, it was not clearly explained in this study, but how the language function score was obtained. But according to another research, we inferred that the conclusion was obtained by comprehensive evaluation of results of ADACOG, MMSE, MOCA, and WHO, WCUNA. So that is basically based on AVLT scale. So the impact of repetitive transcranial magnetic stimulation on memory. So this test is used to evaluate the memory function of patients. So by doing RAVLT test, the subscale, they were strongly correlated. So the result of these two tests were combined for analysis. So in addition, they found that 80 patients did not show any difference in raise 15 words immediate recall and other 50-minute delayed recall. So however, a study that showed that RTMS significantly improved the memory function in patients who received cognitive training. Real TMS CT change, mean standard deviation also changed by 3.87 to 0.82. TMS CT change, that is 0.29 to 1.07. So in this conclusion, we draw by ACE 3 results. So impact of repetitive transcranial magnetic stimulation and executive ability. So the positive, this transcranial magnetic stimulation had positive effect when viscospatial ability and writing movement speed were evaluated using the TMTA test. So it goes from 0.02 to 95% CL. So, however, a positive trend was observed in study by Zhang et al. 2019 on attention and visuospatial function assessed using the ACE3 scale. So the magnetic stimulation and emotion assessed psychological and emotional changes of 80 patients using the GDS scale. It can be seen from the plot. There was no statistical difference in psychological and emotional improvement between the TMS treatment group and the SAM stimulation group. So the clinical global impression improvement, CGI-1, and clinical global impression severity, CGI-S, were used to assess the overall mental state of 80 patients. So it was found that RTMS treatment significantly improved mental state as shown by CGI-S and CGI-S1. So in RTMS group, CGI-S was significantly better compared to the baseline, whereas no significant difference was found between the baseline and after SAM stimulation in the SAM group. So in contrast, when CGI-1 was used to assess the psychological and emotional changes, both RTMS and SAM stimulation significantly improved CGI-1 compared to the baseline. So the bias and sensitivity analysis, it was the funnel plots were visually symmetric. So then we conducted quantitative evaluation through Beck and Egger test, and results showed that publication bias was present. So it was P 0.074 at and P 0.0040. So therefore, pruning and filling tests were used for verification. After pruning and filling, our results did not change, suggesting that they were still robust. So in addition, it should be pointed out, you can see in this figure, the standard error till like 1.5 to 1 to 5 to 0. So this is the funnel plot. You can see the bubble-like structure. It is inside the cube, so it is not going like it's going outside. But the main RTMS on 80 patients that are still available in the plot. So this shows like the meta regression analysis was used to explore the source of heterogeneity, and the results showed that sample size, age, and RTMS treatment effect were not significant at the level of 5%. So this is the sample size, and age were not considered as the source of heterogeneity. So in the level of 1%, stimulation frequency was significant at the level of 5%. So the adverse reactions were reported in 4 of 14 studies. So the main adverse reaction included local scalp discomfort or headache. So in this study, 2 patients, one in RTMS group and another in SAM group, reported transient fatigue. It has to mention that no case of seizure was recorded. So quickly moving to discussion, the improvement of cognitive function following RTMS treatment or SAM stimulation was compared in 14 studies, encompassing a total of 513 Alzheimer's disease patients with varied degrees of disease severity. So we discovered that RTMS dramatically enhanced global cognitive abilities. We discovered that RTMS was beneficial in enhancing daily living capacity when each cognitive domain was included for further investigation. So our findings are in line with the majority of other studies showing that RTMS improves cognition and everyday functioning in Alzheimer's disease patients. RTMS can enhance the plasticity and excitability of cerebral cortex, which will subsequently improve the cognitive performance of AD patients. Even previous research which was done has shown that AD patients' cortical plasticity is impaired, which causes a decline in cognitive function and self-care ability. But due to RTMS test, we have like finally proved that it is enhancing brain plasticity, which both against the memory, cognition, and metabolism of the memory function. So cognitive impairment includes alteration in executive, visuospatial, speech, memory, and other aspects. So our meta-analysis showed that RTMS can improve global cognitive function in patients with AD, which is consistent with findings of a previous meta-analysis study. So the global cognitive function in patients with AD using scales such as MMSE, MOCA, SE3, and ADS-COG, that was consistent and positive results were located. So even though individual study and research we considered had good findings in language, memory, executive function, and affective cognition, the pool findings were not statistically significant. Language is a tool that is for symbolically communicating. Grammar, semantics, and pronunciation are the three facets of language. So in human social contact, verbal communication is crucial. So one of the most prevalent functional deficits in cognitive decline is language impairment. So which first manifest in the early stages of Alzheimer's disease. So performance on language task is a crucial diagnostic indicator for AD and moderate cognitive impairment. So fluency in language, naming, semantic awareness, and discourse processing are the key areas where it shows up. Taylor and Phillips, 2008. So they proved that the language assessment scale, which includes the aphasia screening test, Boston naming test, and word marking test, that is also language test of Wechsler intelligence test. So that is frequently used technique for evaluating language disorders. So other studies were also examined and the effects of TMS on language cognitive domain in AD patients, and the study assessment techniques varied, which made it challenging to perform additional statistical analysis. So we evaluated the patients and the study assessment techniques that varied, which it made challenging to perform additional statistical analysis. So therefore, we described the relevant articles one by one. So we evaluated the patient's listening comprehension ability through the sentence comprehension test and obtained positive results. The results of language function measured by MMSE and ACE3 respectively were not statistically significant. So there's the study of memory, cognitive domain, and RAVLT test was used by evaluation tool to conduct this study, and the results showed that there was no significant statistical difference between TMS treatment group and the SAM stimulation control group. So in terms of executive ability, they did not show positive effects of RTMS when TMT test was used to evaluate viscospatial ability and writing motor speed. But the positive results in attention and viscospatial ability using ACE3 scale. Age-related difficulties were there, such as diminished activities of daily living, ADL, and instrumental ADL, IADL account for 35% of the population that was aged above 65 and over, and make it challenging for senior person to live independently. So IADL refers to a person capacity for using public transportation, purchasing daily necessities, preparing meals, paying bills, managing bank accounts, and other activities. So it also refers to a person level of autonomy and independence with regard to carrying out activities at home, in community. So in terms of daily living ability, positive results were found in IADL indicators. And the previous study that I found RTMS treatment has definite effects on depression and other psychiatric disorders. In a study on effect of RTMS in patient with treatment refractory depression, positive response of patient was related to increased volume of left amygdala and the unchanged volume of hippocampus, whereas the neutral response was associated with the decreased volume of the left hippocampus. And the study reported that an increase in volume of the hippocampus inside of the brain targeted by HFRTMS and was associated with improvement in depression. Again, we analyzed the combined results of GTS indicators. That was we did not obtain positive results. So RTMS treatment could improve the mood of 80 patients. So given the small number of included studies and different scales used in different studies, it is necessary to conduct high quality, larger sample RCT studies to confirm the findings. So meta-analysis also looked at the impact of various RTMS parameters and cognitive performance and discovered that LDPFC by 10 Hz or RTMS, at least 20 sessions were helpful in enhancing cognitive abilities. So our findings collaborate earlier research regarding the effects of various RTMS stimulation frequencies, locations, and sessions in cognitive performance. So the excitability of particular regions of the cerebral cortex can be increased or decreased by RTMS due to variations in stimulation parameters. So the results of our study suggest that 10 Hz RTMS has a more beneficial therapeutic effect on cognitive functioning than HF-RTMS. That may raise brain cell excitability with a ceiling effect. So future high quality, larger sample RCT studies are required to reach an exclusive conclusion. So since the opposite finding from a meta-analysis research, that was asserted that 20 Hz RTMS appeared to be more effective than 10 Hz or 1 Hz RTMS that is needed. But it depends on the extension of Alzheimer's disease in the patient. Prior to using RTMS, stimulating locations used to be chosen. LDLPFC and Precunus were the two most frequently used sites for single site stimulation. As already indicated, 10 Hz had better efficacy than 20 Hz, indicating a connection between the frequency of RTMS and stimulation site. So the meta-analysis published by Liao et al. That was involving 94 patients with mild to moderate AD. It was found that stimulation of right or bilateral DLPFC, which was more superior to stimulation of LDPFC alone. So in contrast, meta-analysis by another researcher, Wu et al. Has found that stimulation of LDPFC by HF-RTMS was more effective in improving cognitive performance than multi-point stimulation. That found that stimulation of LDPFC significantly increased by the percentage of correct response in auditory sentence comprehension, but there was no significant difference in other language abilities or memories. So in addition, we also conducted a subgroup analysis on effect of cognitive training added to RTMS, and we found that cognitive training did not show additive effects when applied with RTMS. And LPSAC on cognitive performance. Cognitive training is basically focused on episodic memory and specifically on face name associated memory. So although the studies separately describe the positive results of RTMS combined with cognitive training, you can later see on the table which is already gone. So therefore, future studies should balance the number of 80 patients receiving the combined cognitive training and those who do not receive this combined therapy in order to better investigate whether cognitive training leads to synergistic effect. So the patients with AD can have their everyday functioning and general cognitive abilities improved with repetitive transcranial magnetic stimulation RTMS. And RTMS significantly enhanced cognition with 20 sessions or more at a single site at high frequency, according to subgroup analysis. So furthermore, we need to focus more on the RTMS safety in AD patients with seizures. Our results should not be taken too seriously due to the limited sample size. So to more accurately determine the effectiveness of RTMS in treating AD patients and the ideal type of stimulation needed to enhance positive outcomes, additional research with bigger sample numbers and longer follow-up periods were required. Thank you. You can send me your questions if you have any questions. Thank you.